Hello, everyone. Please go ahead and find a seat if you have not. There's a lot of empty spaces in the front if anybody wants to move closer to the actual presentation. So welcome to the Fall 2025 Colloquium presentations, or welcome back if you were here this morning. We are now ready for our third presentation of the day. And this presentation will be on, the title is Preventing Childhood Obesity in Harrisonburg. And our presenters are Zada Al-Zayadi, Emily Height, and Emma Varnier. So welcome, thank you.
Good afternoon. Thank you for being here. We're here to talk to you guys about preventing childhood obesity, a culturally informed, family-centered nursing approach. I'm Emma.
I'm Zara.
I'm Emily.
All right, so for introduction, childhood obesity remains a significant public health issue in the United States, and it impacts children and families across all backgrounds. It's not just about weight. Childhood obesity is linked to a long-term physical health problem like diabetes and heart disease, but it also affects emotional well-being and social development. Children who struggle with obesity often face low self-esteem, bullying, and mental health challenges that follow them into adulthood. Because the issue is so complex, addressing childhood obesity requires more than one single solution. It needs a coordinated, collaborative approach. Families play a central role in shaping eating habits and daily routines, but they can't do it alone. Schools are important partners as well. They provide nutrition education, healthy meal options, and chances for physical activity. Healthcare providers also contribute by offering screenings, guidance, and early interventions that support both prevention and treatment. And on a broader level, communities influence health behaviors through access to safe play spaces, affordable nutritious foods, and programs that encourage active lifestyles. When these groups, families, schools, healthcare providers, and communities work together, it creates a supportive environment that can help reduce childhood obesity rates. Ensuring that all children have equal access to resources, supportive relationships, and education is key to promoting long-term health and well-being. Now, onto our objectives. I'll go over the main objectives of the presentation so you know what we'll be focusing on. The first objective is identifying contributing factors to childhood obesity. This means we'll look at the root cause that influence a child's weight, especially in diverse communities. Factors can include things like limited access to healthy foods, cultural food practices, family stressors, socioeconomic barriers, physical inactivity, environmental influences such as unsafe neighborhoods or lack of recreational spaces. Understanding these root causes help us see childhood obesity as a multifaceted issue, not just an individual behavioral problem. The second objective is to explore prevention strategies that are culturally informed and effective. Prevention isn't one size fits all. What works for one community or family may not work for another. We'll discuss strategies like improving nutrition education, increasing access to healthy foods, promoting physical activity in safe and meaningful ways, and engaging families through culturally respectful approaches. The goal is to look at prevention through a realistic lens that matches the needs of the community we serve. And finally, our third objective is to highlight nursing roles in combating childhood obesity. Nurses play a vital role across multiple areas: education, early screening, advocacy, and supporting families with resources. We're often the first point of contact in healthcare, which gives us the opportunity to guide families, identify risks early, and help create supportive environments that encourage healthy growth and developmental. We'll talk about how nurses can advocate for policy changes, collaborate with schools and community organizations, and provide culturally sensitive care. Together, these objectives form the foundation for understanding childhood obesity from a holistic, community-focused, and nursing-centered perspective.
According to the CDC, 19.7% of children and adolescents in America are classified as obese. Obesity is defined as having a BMI at or above the 95th percentile based off of age and sex. Obesity rates increase with age, going from 12.7% among 2 to 5-year-olds all the way up to 22.2% in those aged 12 to 19. Obesity prevalence also increases as family income decreases. 25.8% of children from families with an income below the federal poverty level are considered obese, while only 11.5% of children from families with an income of 3 times the poverty limit are obese. Hispanic and Black children are also disproportionately affected, with prevalence being 26.2% among Hispanic children and 24.8% children being obese among non-Hispanic Black children. So, why does this matter? Obesity among children increases the risks of many potential life-threatening conditions, including heart disease and type 2 diabetes, as well as less severe conditions such as asthma, sleep apnea, and osteoarthritis. Psychosocially, childhood obesity is also associated with anxiety, depression, lower self-esteem, and lower self-reported quality of life, as well as bullying and social stigma. Healthcare costs are also more expensive for those who are considered obese. On average, it costs an additional $116 per person per year for medical care when a child is considered obese compared to a child who is considered to be a healthy weight. For a child who is considered severely obese, medical costs can increase up to $310 higher per person per year. Now, before we go any further, I want to introduce the topic of systems theory as one of our level 3 concepts. This theory states that each individual is part of interconnected systems, where a change in one part affects every other part. Basic principles of this theory include all elements of a system affect each other, the whole is greater than the sum of the parts, systems can be closed or opened depending on how easily influenced they are by outside factors, and a system seeks to maintain equilibrium. This is especially true in the case of children who are considered to be obese, as they are affected by not only the healthcare system, the school system, governmental policies, the environment around them, and of course, their families. We will continue to refer back to systems theory throughout the presentation. So, how does childhood obesity affect our local community? Here in Harrisonburg, adult obesity rates are up to nearly 35%. Data also shows that over 26% of Virginia children are obese, and locally, over 28% of students self-report to believing that they're slightly overweight, while 7.6% think that they're very overweight, according to a JMU study. Additionally, low-income preschoolers in Harrisonburg show a 24.8% obesity rate, which is more than double the national average. Our community partner, the Healthy Community Health Centers, or HCHC, identified a critical need for childhood obesity education and resources here, where many families struggle with limited nutrition knowledge and resource access.
Our primary partner for this project during the semester was the Harrisonburg Community Health Center, or HCHC, which is a clinic here in Harrisonburg that provides accessible healthcare to the city's diverse population. HCHC mission is to promote wellness and provide preventative care, especially for children, which aligns perfectly with our goals for this project. Throughout the semester, we worked with HCHC and our instructor to develop an educational handout that helped families understand healthy lifestyle changes. We also provided resources and practical tips for parents to support healthy habits in their homes. This partnership has been a valuable experience for us and helped us understand how community organizations can play a big role in public health, especially in our topic, childhood obesity prevention. Here is a picture of the handout that our group designed throughout the semester. These handouts focus on everyday tips for children, teens, such as reducing sugary drinks, daily physical activity, and limiting screen time. We also mentioned some local resources for those who are in need, such as food assistance programs and safe spaces for physical activities. We made sure the handout was simple, clear, and culturally tailored, so it meets the needs of our diverse community in Harrisonburg. We also made a version of this handout in Spanish for those who have language barriers to help them better understand the information. The handout was given to patients during their visit at HCHC, which allowed the provider to go over the information and answer any questions when needed, while also giving them a useful source to take home. Creating these handouts was a key part of our effort to promote childhood obesity prevention in Harrisonburg. We also created a SMART goal template designed specifically for nurses and providers to use for their patients during their visit at HCHC. The template starts by asking the patient and their family if they're ready for change, and that question helps the provider understand the patient mindset. Once that's ready, the template will help them create a SMART goal. SMART goal could be identified as something specific, something we can measure, achievable, relevant, and timed. The template also have plans to monitor progress, and this could be as simple as a log at your home or notes on your phone. To support the ongoing progress, we plan to schedule a 90 days follow-up so providers could check in, celebrate improvement, and adjust goals when needed. The purpose of this SMART goal template is to help nurses and providers put their thoughts into a structured, family-centered way to promote change and make prevention of childhood obesity in Harrisonburg more personalized. To take a closer look into these issues in real life, we want you to meet Leah, our case study. Leah is a 13-year-old Mexican-American girl with a PMI in the 91st percentile, classified as overweight. She lives with her mother, grandmother, and 2 younger siblings. Her family speaks Spanish at home. They are insured through Medicaid, and the family doesn't have a primary care provider, and their health is done through free clinic. Leah's mother brought her to the clinic because she's tired all the time and she doesn't like to play outside anymore. Leah's physical assessment. Her weight has increased over the last 3 years. She drinks 1 to 2 sugary drinks a day. Her food is usually microwave meals or fast food. She gets tired easily and feels embarrassed to play with her friends. She has limited safe outdoor spaces. She spent 5 to 6 hours on her phone. Her mother works 2 jobs, and when her grandma cooks, the meals are usually high in carbs. Before we go any further in our case, we have a question for our audience, and everyone is welcome to answer. As we look at Leah's case study, what are some of the modifiable and non-modifiable factors affecting her health outcomes in this case? We will have 2 minutes for discussion time.
You were talking really fast.
Yeah. Okay, so we're at 141. So we need to make it to at least 1, 2.
Go back to it.
It's all.
Too bad. Okay. We can participate when you're ready. You will get candy for each answer. Caitlin.
Caitlin? Thank you. Would you like a piece of candy? Okay. Mm-hmm. Caitlin?
5 to 6 hours of screen time. Screen time is modifiable.
I don't know your names, I'm sorry.
Okay, Arthur was having like a discussion.
Mm-hmm.
He saw that the screen time was modifiable, but as for the sugary drinks and the food, she's just a child and her mom's working 2 jobs. So that sugary drinks, you know, the fast food is big as all of her 4. So I'm not sure if that's, and she's also just like Hispanic.
Mm-hmm.
And usually in those countries, they have, you know, high fast food, like carbs and salt. So I don't know if that's like cultural insensitivity
We do discuss that later on when we talk about the interventions that are provided for her, but you are partially correct. Sorry, it's a little hard to hear you back there, so I think you said, oh, Wendy's coming.
So yeah, like Laan said, like there's some things that are out of control just because the mom works 2 jobs. But for things like microwavable food, if there's a way to cook it on the stove or put it in the oven, that might be a better option. And then even like some of the high carb foods, adding like vegetables or maybe affordable fruits and vegetables to it to at least like balance out her diet within like the given, what is it? Yeah, with the financial parameters that the mom has. Just, adding things to make it a little bit healthier instead of like trying to buy things that are too expensive, if that makes sense.
I think she made a good point that like it's good to be culturally sensitive, but to address someone to sugary drinks daily, I think that ultimately falls in lack of diet education from the parents. Her age is what, 13 years old? 13 years old, I would love to have sugary drinks all day, but it also comes from proper education. And, I think there's ways to mitigate, like if you can't access the best of quality foods, if you can access the sugary drinks, things like water, you can cut juices, half water, half juice. So I think that there's opportunities to like mitigate that issue.
Thank you all for participating. Almost all of the factors in Leah's case study are modifiable, which gives us a lot of opportunities for change. Please keep Leah in your mind as we move forward. We will be visiting her case study later in the presentation.
Moving on, we're going to look at the major barriers that families in Harrisonburg face when it comes to preventing childhood obesity, and I want to tie these directly to systems theory. System theory reminds us that children don't exist in isolation, and they are shaped by multiple interconnected systems, including family systems, community systems, cultural systems, and healthcare systems. When these systems have gaps or breakdowns, it directly affects healthcare outcomes. Starting with family access challenges, we see how the community environmental systems influence families' daily choices. Limited grocery store access, the high concentration of fast food locations near low-income housing, and the restricted public transportation are all structural issues, meaning the system itself is limiting healthy options. Working families with inflexible hours face even more barriers because the system doesn't support time for grocery shopping or preparing balanced meals. These environmental and economic subsystems shape behavior long before personal choice even enters the picture. On the right side, we have cultural and language barriers, which reflect gaps within both the healthcare system and the cultural system. Harrisonburg has a diverse population, but nutrition labels aren't translated. Health information may not be culturally relevant, and families may struggle to navigate the healthcare system. Providers may not fully understand a family's cultural dietary practices, which can lead to miscommunication or ineffective recommendations. When the healthcare subsystem doesn't align with cultural subsystem, families are less able to make informed and sustainable changes. Finally, the slide mentions the long-term impact, higher rates of obesity, hypertension, and diabetes in adulthood. Systems theory helps us understand that these long-term outcomes are not just a result of individual behaviors, they're the cumulative result of multiple systems interacting over time. When community resources are limited, when healthcare communication isn't accessible, and when cultural needs aren't integrated into care, the entire system contributes to poorer health outcomes. This slide highlights how addressing childhood obesity requires a system-level collaboration, strengthening transportation, improving food access, building culturally appropriate healthcare resources, and supporting families with policies that make healthy choices feasible. Moving on, I'm going to come back to Leah that we talked about earlier. The key reasons why maintaining a healthy lifestyle is difficult for Leah, and each of these challenges connects back to the barriers we identified in her case study. First, Leah lives in an unsafe neighborhood, which limits her opportunities for outdoor physical activity. Because she can't safely play outside, walk to parks, or participate in after-school activities, she ends up spending over 6 hours a day on screens. This is a perfect example of how a child's environment, not personal choice, shapes their health behaviors. Next, we see busy parent schedules. Leah's parents work long and flexible hours, and as a refugee family with limited income, they're often juggling multiple responsibilities. This means there's less time for grocery shopping, meal preparation, or participating in family physical activities. For Leah, this leads to resilience on convenient, inexpensive fast food options. Financial strain is another major factor. Healthy foods tend to be more expensive and less accessible in low-income neighborhoods. With limited resources, the family prioritizes affordability and convenience over nutrition. This aligns with what we see nationally: economic stress narrows food choices. We also have language barriers, which affects Leah's family both inside and outside the healthcare setting. Nutrition labels may not be translated, health instructions can be difficult to understand, and navigating school or medical systems becomes overwhelming. As a Spanish-speaking refugee family, they may not always receive culturally sensitive or linguistically accessible health education. Finally, limited healthcare access plays a role. While Leah has been seen by providers, we know that families facing language, cultural, and financial barriers often delay preventative care. This can lead to missed opportunities for early intervention, counseling, and ongoing support for weight management, mental health needs, or bullying concerns. Together, Leah's case shows us that her challenges are not the result of individual choices, but the combined impact of environmental, socioeconomic, cultural, and family system barriers. Understanding these factors help us approach her care with empathy and teaches us how important it is to address obesity from a systems-based, family-centered perspective.
One thing that we focus on in Level 3 is the importance of basing our interventions on evidence-based research. With that in mind, here's some of what we found. When it comes to reducing rates of childhood obesity, research shows that behavioral and lifestyle changes are more effective than dieting and focus on weight. Assessing risk factors and implementing early interventions showed the most promise among the research that we found to reduce rates of childhood obesity. Pierre and colleagues created a family nutrition and physical activity screening tool, which helps to capture 10 family-based practices and youth behaviors that were found to have strong evidence in their evidence analysis as predictors of childhood obesity. These youth behaviors included drinking large amounts of sugary drinks, poor diet, and large amounts of screen time. Other research that we found supported these findings. Epstein and colleagues showed that families who got coaching from behavioral change specialists, as well as individualized counseling on healthy eating, physical activity, and improving parenting practices related to weight and behavior change, had a significant reduction in percentage above the median BMI when compared to their control group. Drakowski and colleagues showed that providing culturally tailored education in a family's native language increased a parent's awareness of the issue and led to healthier food choices, reduced screen time, and increased physical activity among children. Additional studies showed that integrating education opportunities into school, primary care, and home-based interventions led to more consistent results. So, how do we translate these evidence-based solutions into practice, particularly within healthcare and nursing settings? The key is taking a family-centered approach. Rather than just telling families what to do, we need to provide education on healthy nutrition and appropriate activity levels that meets families where they are. This means using culturally tailored teaching methods to make health messages truly meaningful and relevant to each family's context. One particularly effective strategy is motivational interviewing techniques. This helps parents move beyond just receiving information to actually setting realistic, achievable goals that fit their family's lifestyle and circumstances. But family education alone isn't enough. The evidence clearly shows that we need multi-system collaboration. Healthcare providers can't work in isolation. We need to actively collaborate with schools and community health organizations, provide continuity of care with robust follow-up support, and coordinate our efforts across healthcare, educational, and community settings. When we implement these culturally tailored, community-based interventions in a coordinated way, the research demonstrates significant results: increases in parental education and engagement, healthier food choices, reduced screen time, and increased physical activity. This integrated approach is what makes the difference between simply providing information and actually creating sustainable behavior change. When it comes to Leah, the individualized care that her health care provides for her allows a major benefit to her potential health outcomes. First, the provider offered Leah nutrition counseling that was culturally relevant to her family's background and income. Instead of giving generic diet advice, the provider discussed healthy food options that fit within her family's traditional meals and budgets. This helps families to make realistic and sustainable changes. Next, the provider encouraged increased physical activity, but tailored those recommendations to what was actually accessible in Leah's environment. Since children in Harrisonburg may not have safe outdoor spaces or sports opportunities, suggesting simple activities that she can do at home, such as dance breaks, allow her to get in physical activity while remaining safe. The provider also recognized that emotional health plays a big role in eating habits, and Leah mentioned that she was embarrassed to play with her friends, so her providers referred her to the school counseling for emotional support. Another important step is connecting Leah's family with local food assistance programs. As someone over here in the back mentioned, her mother is often busy and they don't have a lot of money to spend on food. So connecting them with local programs gives them an opportunity to have more nutritious food without adding additional financial strain to them. Finally, this provider scheduled follow-up visits to monitor progress and adjust the plan as needed. These ongoing check-ins help keep Leah and her family motivated and give the family a chance to ask questions or address new challenges as they arise. With these culturally tailored goals, emotional support, and strong family involvement, Leah has a much better chance of improving her energy levels, eating habits, and physical activity over time.
To zoom out and look at what's already working in Harrisonburg. In Harrisonburg, we're seeing several community qualities that really support children's health. First, many families in the area have strong values around sharing meals, staying socially connected, and taking care of one another. This foundation makes it easier for us to introduce new health information, especially since the families are already used to working together. We also have a very active faith community here in Harrisonburg, including local Arabic and Kurdish mosque, Egyptian and Ethiopian churches. These spaces are more than spaces of worship. Sometimes they provide health education or wellness programs. Especially for families who might be new to the area, these communities offer familiar language and culture. Another major quality we have in Harrisonburg is the partnership between schools and the community. Many schools collaborate with the local organizations to provide physical activity programs, after-school activities, nutrition education, and family outreach. This partnership helps support healthy habits in students beyond the classroom setting. Harrisonburg has a number of community gathering spaces, parks, and playgrounds where children can be safely active. These spaces are not only to promote physical health, but also help families build relationships. Altogether, these qualities create a supportive environment that we can build on when designing interventions for childhood obesity prevention in Harrisonburg.
So the question becomes, how do we leverage these existing strengths in our community to create meaningful change? The answer lies in partnering with trusted community organizations and providing education that's not just evidence-based, but also culturally tailored and linguistically appropriate. We need to meet families where they are, literally and figuratively, reaching them in the spaces they already trust and supporting sustainable behavior change. Here's a few ways we can do this. First is with faith-based education. Since we already know that the Mennonite community is great at outreach and there are many mosques and cultural churches within the community, we can partner directly with these organizations to offer nutrition workshops. This will let people host cooking demonstrations using familiar ingredients or physical activity sessions for families in these already familiar, comfortable settings where people come together. Secondly, school programs. We already have strong school partnership in Harrisonburg, so we can build on that. We can integrate health promotion directly into school settings, not just for kids, but for whole families. This could include family wellness nights, after-school activity programs, or nutrition education that students can take home and share. Third, very important, is native language materials. In our diverse community, which has a large number of Spanish-speaking, Arabic-speaking, and Kurdish-speaking families, we need to provide resources in their native language. This isn't just about translation, it's about creating materials that are culturally relevant and resonate with families' values and traditions. When we work through these trusted channels and provide culturally appropriate support, we're not imposing change from the outside. We're empowering communities to create healthier futures from within.
Bouncing off what Emily said about creating change, now I'm going to be talking about policy level changes. Because long-term progress in reducing childhood obesity depends on decisions made at the community, state, and national levels, individual and family-based interventions are important, but policy is what builds the environment people actually live in. One key area is increasing access to affordable preventative health care for children and families. When families can easily access screenings, nutrition counseling, and early interventions, we can address health concerns before they become more serious. This also reduces the financial burden that often prevents families from seeking help. Next, we need policies that support community infrastructure for safe physical activity. This includes investing in parks, sidewalks, bike paths, and recreational centers. In many areas, children don't have safe places to play outside, which directly contribute to low activity levels. Strong infrastructure gives kids more opportunities to move throughout the day. We also know that many communities struggle with limited access to nutritious food. So another important policy initiative is improving food access in underserved neighborhoods. This can include bringing in grocery stores, funding mobile markets, or supporting nutrition assistance programs. When healthy food is available and affordable, families can make better choices. Finally, schools play a major role, so policies should mandate culturally appropriate health education. That means teaching nutrition, physical activity, and overall wellness in a way that respects families' backgrounds, languages, and traditions. When education feels relevant and inclusive, it's more effective and easier for students to apply it at home. Overall, policy-level changes build healthier environments that support children and families, making it easier for everyone to make healthy choices and reducing the overall burden of childhood obesity.
Gaps in research. As a group, we found some gaps in this research about childhood obesity prevention. First, we don't have a lot of studies that show the importance of culturally tailored interventions, even though culture has a strong and a big impact on what families eat and how active they are. We also need more research on nurse-led interventions, especially in diverse communities. Nurses often spend a lot of time with the patients and their families, so understanding how effective their approaches are is really important. Another gap that we found is we don't have enough information on the cost of multi-level program. Knowing whether these programs are affordable and sustainable help guide the future planning. Overall, we need stronger evidence to support long-term, culturally tailored strategies for preventing childhood obesity in Harrisonburg.
Now, I want to connect our discussion back to the broader values that guide us as nursing students and future healthcare professionals. This is EMU's Sacred Covenant, which we centered around these three of the key terms: empowerment, partnership, and advocacy. These themes shape not only how we care for individuals, but also how we interact with families, communities, and systems, especially when addressing complex issues like childhood obesity. First, empowerment. In the context of childhood obesity, empowerment means supporting families so they feel confident making healthy choices. It's not about judgment, it's about giving them the tools, knowledge, and motivation they need. For example, helping parents understand nutrition labels, connecting them with affordable food options, or involving kids in age-appropriate goal setting. Empowerment allows families to take ownership of their health journey. Next is partnership. Childhood obesity cannot be solved in isolation. We must partner with families, schools, healthcare providers, and community organizations. This is especially important in diverse or underserved communities where there may be cultural or socioeconomic barriers to care. Partnership means listening, understanding lived experiences, and collaborating instead of prescribing. It reminds us that effective prevention and intervention require shared effort. Lastly, advocacy. Nurses play a major advocacy role, whether that's advocating for healthier school meal programs, safer spaces for physical activity, or policies that increase access to preventative services. Advocacy also means standing up for families who may face stigma, language barriers, or limited resources. It's about ensuring equity in healthcare and pushing for systems that support long-term health. Overall, EMU's Sacred Covenant reinforces the values that guide our nursing practice, empowering those we care for, partnering with communities, and advocating for systemic change. These principles align directly with our mission to approach childhood obesity with compassion, cultural sensitivity, and a commitment to justice.
In the end, childhood obesity isn't just a diagnosis on a chart. It's a reflection of the systems that surround every child: families that are stretched too thin, neighborhoods without safe places to play, and grocery stores that are too far away, and healthcare that too often forgets to speak a family's language or honor their culture. But systems can change. When nurses step in with evidence-based tools, culturally tailored education, and real community partnerships, Like the ones we built with HCHC this semester, we move the entire system towards health instead of blame. As EMU nurses, we carry the sacred covenant to empower families, to partner with communities, and advocate until every child has the same shot at a healthy future. Thank you for listening.
Thank you.
Yeah. We do, I think, have a little bit of time for questions if anyone has anything. Caitlin. Wendy's coming over, so.
What's your favorite part? What was your favorite part of the project?
My favorite part was working with Holly at HCHC. It let me see a level of care that I haven't really seen before in clinicals, and it was just really a unique experience.
I agree. I think Holly is an amazing instructor. She helped us a lot throughout this project and grading the handouts. So I think my favorite part was doing the handout.
Yeah, for me, I want to work in peds when I graduate, so getting to work around kids was really great and gave me a lot of experience, so.
Thank you so much for this wonderful presentation. Quick question. I heard you clearly reiterate multiple times that obesity in childhood is not, the major factor is not individual decisions or behaviors, but it is related to the systems in which children live. So it sounds fair to conclude that the disparities in childhood obesity are largely a result of social determinants of health. Mm-hmm. I'm wondering if you had any preconceived ideas prior to researching and exploring this issue that changed after your experience in exploring the research and the situation itself.
I didn't quite expect there to be, I knew there was a disparity between income levels, but I didn't expect it to be quite as big as it was. And I also didn't realize how much of a difference there was in Harrisonburg compared to what there is in Virginia. So that was a surprise for me.
Personally, I didn't have a lot of information about the topic or the background of these issues, so learning about this topic has been a great experience. I learned so much about how culture can impact children.
Yeah, I kind of have to agree with Zara. I didn't have a lot of prior knowledge, so doing it kind of expanded what I already knew a little about, so.
At HCHC, did y'all sit in on doctor's visits with the children or just get the statistics from there?
When I was with Holly, I managed to sit in on some of her appointments, though she was mainly speaking with Spanish-speaking families, and I don't speak Spanish, so Holly was translating for me and I was observing. But I do think it was a very helpful experience.
We also had an orientation about the background and the patient population in HCHC, which helped us with a lot of information.
Any other questions? All right.
Thank you all
Thank
for
you.
listening.
Thank you.
So let's give all three groups another round of applause. Thank you, Level 3 students, for providing us with the content, the presentations today at our Pi Mu Scholarship Day. For those of you that don't know, and I was not here this morning, so I don't know if anybody talked about Pi Mu, but it is our chapter of our International Nursing Honor Society. And we are the sponsor of this day today. So a thanks to our Pi Mu officers and our wonderful Sam, who helped arrange our exhibitors out there. And to, let's see, Kate is our vice president, Laura is our president, I am the awards committee chair, Monica is our something, and Don is our something, and eligibility coordinator. So, did I miss any officers? So that's our team with PIMU. So hopefully this is a taste of a professional development experience and like a professional conference. And as nurses, you should be a lifelong learner. And so hopefully this is the first of many of these types of experiences that you will be able to do. And hopefully it's the first of many professional presentations that our level 3 students will do. They're now prepared. It's always a pleasure to watch them in conceptual framework and now. And the other part of a professional conference or a professional development opportunity that in order to get your continuing education credits or other types of credits, you fill out an evaluation. And so on your page, and I think there might be a slide. Clay, is there one more slide with a QR code or not? Yep. There is a QR code on your brochure here and also on the screen. If you'll take a moment to fill out that very short evaluation of the day-to-day, we would much appreciate it. And thank you and have a happy Thanksgiving.